What's up? Bill Bogenreef here for Nor-Cal EMS, introducing our first live webcast for continuing education. This webcast is presented by Dr. Eric Rudnick and Kara Davis. Join Dr. Rudnick now as he introduces EMS at a Quality Crossroads before diving into the subject continuous quality improvement.
We are starting out with a basic program on continuous quality improvement. For those of you who don't know what that is, that's quality improvement is about how we improve the care that we deliver to patients and how we can improve our organizations. Much of the reforms in healthcare really has been started by the Institute of Medicine, the IOM. Back in 1996, the IOM published a report, EMS at the Crossroads, and it really talks about how we in EMS need to look critically at what we do. Many other organizations do, even though we don't quote-unquote build widgets, where much of the quality improvement programs have started. We can learn much from that. And whether we like it or not, healthcare, that includes EMS, is changing, and the public will demand that we critically look at ourselves and eventually put this type of information for the public review. The consumers want to know how we're doing and what we're doing. If you watch what's happening in healthcare, with more and more hospital data being displayed, I think that it's just a matter of time that the public will start demanding dissemination of performance on EMS. Whether you're a paid department or even a volunteer department. And healthcare, particularly EMS, starts at the dispatcher level, first responder, EMT, includes the paramedic, and all the way to the hospital and the transition of care. It's all part of this same continuum. I know that there are several LEMSAs, local EMS agencies in California, that are doing integration from the first responder into the hospital chart, and it's one big continuum. I know San Diego, University of San Diego, is really pioneering this. So what is continuous quality improvement? Well, it's a concept that is not new to EMS, but it's not originated in EMS. It's a process. Many industries have developed this. Everybody thinks about CQI and Sigma 6, and Sigma 6 is much more the statistical pieces. These processes were initially developed in other industries that produced quote-unquote widgets. They produce things. We don't produce things in EMS. We're in the service industry. However, all industries can benefit from looking internally and looking at what we do. Healthcare really has embraced it, and I think EMS has been lacking to a certain extent. And we analyze the issues from direct patient care to even how we maintain the vehicles. All are parts of how we can improve the system of care. The big thing for me in quality is that you focus on the system of care, and it's not always about the individual. How do you make things better? Because many, quote, individual mistakes, deviations from what an ideal practice is, can be eliminated. I was talking to an EMS administrator, paramedic, who at one point, there were lots of mistakes between epi and atropine being made many decades ago. And it's because they had the same boxes and the same labeling. So unless we look at how we do things, and we can redesign systems. By definition, CQI, continuous quality improvement, it's non-punitive. I know that when I went through medical school and residency, that the quality piece was very punitive. And anybody who watches, Grey's Anatomy, and they see morbidity and mortality around, it was really based about you screwed up and you need to take complete and total responsibility. Well, I don't think that's necessarily fair, and you need to look at how you analyze things. And I think if you really believe in quality improvement and how you look at things in other industries also, you look at how systems work. Okay. Okay. No.
Thanks for joining us. I just heard another beep out there.
Okay. And for some reason, the slide is not advancing.
Let's see.
There we go. Never mind. I figured it out.
I
am
went
technical.
Too far.
You just wanted us to really focus on it.
I'm a little technologically challenged. Excuse me. So, when you talk about stakeholders, there are internal and external stakeholders. External ones, the general public, organizations outside EMS. I'll talk more about this, particularly for the fire departments. Internal stakeholders are the individual providers within your organization, organizations within an EMS system, and you can get surveys to better improve what you do, how you do it. Can somebody... Was there a mute that was not on? Okay. So, long-term goals. This is from Pre-Hospital Disaster in Medicine back in 1992. So these are not new concepts, but quality improvements in EMS will most likely fail as it has done in many U.S. companies if it's viewed as a quick fix. This is really a cultural change. And NHTSA, back in 97, talked about experience from other fields show that integrating quality improvement Sorry guys, we're having some technical difficulties. Okay. As I was saying, NHTSA back in 97, experience from other fields show that integrating quality takes years. Now I know a lot of departments review charts, review cases, and what I'd like you guys to start thinking about is doing this more in a systematic level, and we'll go much more into much more detail. Okay. So, I love this quote. This came out of the fire system. Quality assurance is to medical care what editing is to a newspaper. A chance to catch mistakes and make appropriate adjustments before any harm is done. And that's what we're all about, is making an adjustment because we're here to serve the public and make sure that they have good outcomes. This also comes out of the fire service, and these are quotes from fire chiefs in the Midwest and Ohio in particular. But 80% of all consumer choices are associated with personal recommendations, and each dissatisfied customer is likely to share his or her view with an average of 11 other people. So if you're a small department and you're struggling to get buy-in with your fire or a paid department, you can lose support from the voters. And those are some of your stakeholders and customers. So let's get a little bit more into the meat and potatoes and enough of the introduction and, pardon the expression, fluff. There are several different parts to CQI. Prospective, which is the hardest to do, and you really want to go about doing preventing potential injuries. So how do you do that? You identify what is known as high-risk procedures and scenarios. You provide education, whether it's the primary education or ongoing education. You analyze the system that you're working in, what areas of patient care are prone to breakdown, doing periodic skills examination, preceptorships. And if you haven't done a formal CQI process, try doing it. I think unfortunately, it's state mandated. It's not something that is new with Nor-Cal, but the state really requires all departments to do some sort of CQI, and we want to make it as user-friendly and as easy for people as humanly possible. We don't want you filling out tons of paperwork and doing tons of work, particularly for our rural and volunteer departments, because this is not your full-time job in many cases. But we are under a mandate to gather intelligence and data. So, prospective CQI, we have a medical advisory committee that develops new policy. I think that I encourage everybody to dial in. We have it every other month. I'd like to eventually establish a working group for the BLS departments to work on beefing up our protocols and our introspective look at basic life support. If you don't provide an orientation to your EMS system, then doing an orientation to the EMS system is part of a prospective approach. And then when you do find an issue, a training issue, how do you disseminate it to everybody? How do you let people know when there are changes to EMS policy and protocol? How do you track it? How do you close the loop, so to speak? Concurrent. Well, that's why we go out and monitor and evaluate different agencies. For me as the medical director here in Nor-Cal, this is kind of difficult in the fact for the direct field observation, because I have 6 counties that are huge, and in order for me to go out and see people actually working in the field, that would be a very difficult thing, because some of you only do 60 or 70 calls, maybe 100 calls a month, maybe sometimes less. So the other thing that field observation for supervisors or your fire chief, mentoring extra set of hands, and those people should never assume care unless, of course, you're asked to. What we're all used to doing and thinking about is retrospective CQI. And how do we identify these issues? Well, commonly it's a complaint from an agency, an individual provider, from a patient. As I said, one of the things that will undermine your support as an agency is if you don't listen to complaints or issues that are brought to your attention, you'll lose the support of your voters and or your constituents. You review the PCRs, patient care records. Is this a random or a focused review? Was this what's known as a sentinel event? Meaning there's a potential bad outcome, and there's a potential for this to happen once again. So you do what you do is a root cause analysis. Dig down deep and really think outside the box. What caused this? Was it truly just an individual provider issue, or was there a systems issue? So, I know there was one fire department that had a hard time remembering to ask patients before they gave them nitroglycerin whether they had taken any of medications like Cialis, Viagra, Levitra, because if you give any of those erectile dysfunction drugs and nitroglycerin, you can kill a patient. It's very easy. Their blood pressure drops down to nothing, and it's not responsive to fluids. So what they did is to eliminate the ability to forget to ask those questions. On every bottle of nitroglycerin, they put a little tag saying, "Did you remember?" It was a simple fix. They ask the questions 100% of the time now. Or in this root cause analysis, is this a once-in-a-lifetime career occurrence that they'll never see again? So more about retrospective quality improvement. You implement education. You engineer change to delivery a system. How do you disseminate the information? Key piece is the loop closure, and make sure that once you start your process of looking at what's happened, is that you go back and make sure that those changes that you've identified are implemented. You reanalyze it. Another example of retrospective CQI are run reviews, which I think are great. You focus on the education. It's always got to be done in an anonymous fashion. You want to protect the patient and the individual provider because you don't want anybody beaten up. So do you do a random versus a focused review? So in small departments, a lot of times you can do 100% review of all records, or in a larger department, you review 100% of all your providers. Now, Gestalt is good. Your gut feeling is good, but you can miss important topics, and that's why you have to have specific criteria. You track things, you trend data. Now, you say, well, I only do 100 calls every 6 months. Well, if you send your summary data to us and we start analyzing it with everybody else's data, anonymized, of course, then we can pick up trends that we can lead to protocol revisions and protocol changes. How do you focus on where you're going to put your attention? What do you do a lot of? What's a high risk, low volume issue? Some of the high risk, low volume issues are AED application and the delivery of shocks. King Airway, another one. Training on tourniquet use, which is now allowed in Nor-Cal. Because, if you've got somebody who needs a tourniquet, the time to be reviewing how to use that tourniquet is obviously not at the scene. And you need to be able to think about it. And every time you put on a tourniquet, you probably should review that run. Did it go as well as it could have? Did they apply it appropriately? Did the patient have a good outcome? Was the key information given to the providers at the hospital when the tourniquet was applied? What the indications were that they really did have uncontrollable bleeding? Again, as an agency, we can aggregate data, analyze trends from the individual provider all the way up to regional to outside comparisons. You can data monitoring and validation to make sure your data is clean. And eventually, I'd like to be able to start doing benchmarking interagency to even to the national level. You say, well, why do we need to benchmark? Why do we need to do all this? Well, I can tell you because I sit on the scope of practice committee at the state level, and I'm an EMS commissioner, and I stay involved in trends, is many ALS procedures, such as intubation, may go away because the national data shows that many times are poor outcomes with intubation. And I think that we haven't looked how we perform some of these high-risk procedures well enough. There are medications that are key to Nor-Cal that we ask for information on that we haven't been receiving, and it makes it very hard to justify at a state level keeping these in the scope of practice. One thing that you need to be leery about, though, with all retrospective review is something called outcome bias. And this is out of Annals of Emergency Medicine back in 2007. There's a tendency for all of us to judge the quality of what somebody did, their decision-making, and what they are like a person based solely on the outcome of the case. You need to really look at the case and say, you reconstruct the events. Put yourself in that person's shoes. You need to be very careful, as I've written here, assigning cause and effect. Would you have done the same thing? Talk to the provider. Find out what the circumstances were. Hindsight and outcome bias is not necessarily a conscious decision, but many times we have preconceived notions of what's going to happen. Hindsight bias as this quote from Weers again shows, when you're out in the field, it's lots of disjointed and disorganized information that we intuitively as healthcare providers put into a coherent framework, causal framework. And a lot of times the reviewer who has all the pieces of the puzzle can try to explain what really happens. And that's not always the case. And having done more chart review than I care to think about, it's very easy to fall into this trap. And a lot of times your initial gut reaction is, well, how could they have done this? Well, you need to think about putting yourself in their shoes. This quote I just love, a mistake follows an act and names it. An act, however, is not a mistake. It becomes mistaken. So let's go through an example of CQI. High-speed motor vehicle accident, rollover, driver ejected from the vehicle. Front seat passenger needs to be extricated. Driver is found to have an amputation of the leg below the knee with bleeding that can't be controlled with pressure and standard measures alone. Tourniquets applied successfully. The air medical resources are requested to transport the driver immediately to the trauma center. The passenger is can be transported via ground to the trauma center. So, prospective. Did the people have the training of the patient destination policy? Where was the nearest trauma center? Did they know that beforehand? Did they know about the application and the indications for the tourniquet? Did they have the knowledge and the training for the trauma triage criteria for the trauma victims? And had they been oriented to the local resources? This is common sense practice, but this is actually prospective CQI. If it was a really big scene, did some other people come and help? And look at how those individual care providers were doing care. And then the easiest to do, retrospective, the analysis of the prolonged scene time. Well, they had to be extricated. That's why they had a long scene time. The review of the documentation of the application of the tourniquet. Was the time that it was applied documented? Was the time conveyed to the hospital? Peer review of the speed with which the initial evaluations, the review of the BLS and ALS interface, which can be crucial. A lot of this work was done by W. Edwards Deming, who really was an engineer who revolutionized the way Japan did things after World War II. They basically took an industry and a country in ruins and made them into the powerhouse that they are. And you plan, do, check, act. It's a simple cycle. And as you can see, there's a choke block to make sure that you don't backslide. And it can be doing quality improvement, business. General Electric is a well-renowned company. Jack Welch, the former CEO of GE, believed in quality improvement. He believed in actually 6 Sigma, which is really just 6 standard deviations what the ideal is, what the ideal widget is. And they feel that 6 deviations away is as close to perfection or a consistency as you'll ever get. GE consistently produces quality products, has eliminated waste and improves efficiency, and delivers profits by these above-mentioned actions. They think about what they're doing in the processes. So, focus PDCA. You find what you want to think about, what you want to do. Start slow, don't be overly ambitious. The O for focus is organize an effort on improvement. In a small department, you might be an army of one. After showing the results, you may be amazed at how many people want to help. Clarification of the knowledge of the process. What do you want to change? Be as specific as you can. You focus the question. Understand how these things can be interpreted depending on the variations. Select strategies. A lot of times small stepwise changes are easier than massive overhauls. Be realistic in your scope. That's something that I constantly have to be taught over and over again when I do these things, is I have grandiose plans and I'd like to make sweeping changes in the large projects because I want to improve what we do with quality improvement in Nor-Cal. This is a huge project, particularly given the variables from small departments to large departments. So the P, as the PDCA, you plan the change, you state the objective, you make predictions on what you think will happen. You plan to execute the test, the change, who, what, when, where, and why. You carry out the changes. You document these, and then you look for data analysis. And you check. So what were the results of this change? Does the interpretation validate your assumption? What did you learn? What went right? More importantly, what went wrong? Many times in my career, I learned more from failures or things that didn't go right than actually when everything went according to Hoyle, so to speak. And then you summarize the data. And this is a lot easier than people realize. If you just take it in small steps, small bites, you know, it's a corny old expression, but how do you eat an elephant? One bite at a time. And then A is you act, you adopt the change, whether entirely or partially. You may have to abandon it because it didn't work. You run through the cycle again. And do you need to make additional changes to the process that you just looked at? So in a PDCA cycle, what are you trying to accomplish? What are you trying to accomplish? How will we know what a change is an improvement or not? What change can be made that will result in an improvement? And how do we keep our gains and prevent backsliding? This I shamelessly borrowed from El Dorado County. Thank you, El Dorado. But this is what I really want us to start doing in CQI. Peer review and focus studies goes to collaborative learning, and I think this is our first venture, and I hope one of many, into collaborative learning. Implementing change. Then you go to the best practices, whether it's a clinical change, an operational change, or an organizational change. And you go back and you study again. Again, the tenets of CQI, it's non-punitive. This is not whack-a-mole. You know, somebody steps out of line, you don't hurt them. You try to work with them first. It's a confidential process, and it's all because we share a commitment to excellent pre-hospital care that we're here. The cornerstones of care. I think the first responders and EMTs are the cornerstone of care in the pre-hospital environment. I can't tell you the number of cases that I've seen over my career where the breakdown in patient care with advanced providers, paramedics, started with the basic life support, that they didn't do solid BLS skills. It is amazing. If you look at the cardiac arrest data and airway management issues, if you look at cardiac arrest as a whole, the American Heart has recognized that good CPR and a good BLS airway is where it's at in resuscitation. With the ventricular fibrillation or ventricular tachycardia arrest, early defibrillation and early CPR saves lives. Not intubation, not medications, good CPR and BLS skills. The other thing that we need to think about is, you know, for the smaller departments, I'm preaching to the choir, but we all need to remember that EMS is a team sport. There's a new trend, again, in healthcare called accountable care organizations. And what they're really looking at is the team approach with outpatient and inpatient blending of roles and responsibilities. I think in the future we'll see much more appreciation and integration of EMS. The future of EMS. Well, data systems that will blend dispatch through hospital discharge. This is happening already. How do interventions in the field impact a patient's outcome? For years, we've just rolled things out from the ER and from the hospital into the field without knowing whether it's going to positively or negatively impact. What transpires in EMS is based upon, unfortunately now, consensus of panels of quote-unquote experts. We still are in the infancy of research in evidence-based medicine. An example is hyperoxemia. Well, what's that? Well, in stroke and other healthcare diseases, having too much oxygen actually may be harmful. And it's actually being looked at the molecular level. So we're not changing protocols yet, but you might look in the future where we routinely automatically put 100% non-rebreather on patients. Well, we might not do that in the future. Some departments are starting to look at that. The other thing, too, is what is considered ALS care now in the future, and I hope in California, in spite of our regulatory constraints, many things that were ALS will become BLS. So why are we doing this? Well, I want to inspire people to improve themselves and improve the care they give the people. This is a process. People will improve themselves as well as improving the care. If patient care is job number one, then evaluation and improving care delivered needs to be job number two. Why do I need to do this, people will tell me or ask me. I know that we deliver excellent care to people. Well, this is a dangerous assumption. Critical thought and analysis can always improve what we do. Whether it's done informally or formally, we need to evaluate what we do. This is true no matter what profession or field you work in. The other thing that I don't want to underplay is analysis and critical thinking is hard work. It really is. Why do we need to do this? We only deliver first aid or BLS care. There's no such thing as we only deliver BLS care. I really believe that. The first assessment is seen and patient can determine the early activation of air medical resources, for example. Cervical immobilization can be critical for trauma patients. Oops. Tourniquet care is a critical skill which needs to be performed appropriately every time. Checking the neurovascular status before and after splinting to avoid damage to the extremity. If you don't check capillary refill sensation and motor before and after, bad things can happen. No delay in oxygen therapy to patients who need it. It's not always about the high-risk interventions such as AED and King airway use. And again, many BLS skills commonly performed today were once only used by ALS providers. The AED is a classic example, and this trend will continue. What I'd like to do is convene a working group of first responders and EMTs who I think have been, I don't know whether ignored or marginalized are good terms, but I don't think we paid a close enough attention to the basics and cornerstone of care. Being a small provider and volunteer doesn't prevent you from succeeding. So I'm going to reach out in the near future to get this working group. And I'd like to convene a CQI quality working group. So what's the impact? Well, peer-driven process will empower providers. You get a sense of ownership. You can make abilities to change both at the local and regional level. I can't tell you the number of changes when we put out protocols that I make based on provider input. I clearly know that I don't have all the answers. Yes, there's astonishment in the room here. It will contribute to self-esteem, professional recognition, which I think is all too frequently overlooked, provide growth both professionally and personally. So the challenges that you face, developing the quality improvement systems may be a new concept or maybe new to formally do it. Small and or volunteer organizations Time and money. I can't tell you the number of times that I've heard that. As a rural environment department, you have very limited resources. And trying to find the, quote, right focus is very difficult, and not being overwhelmed. Getting buy-in from your superiors, from above, and laterally from your peers. You may initially be an army of one, but once you start breaking down the barriers, things will open up. Ensuring loop closure. How do you ensure that if you make a change, how do you make sure everybody gets it? How do you disseminate the information? How do you move from a reactive process that when you see an issue to a proactive process? How do you guide education? And education, I think, is key for all quality improvement. It's very difficult, though, with people leading busy lives, particularly in volunteer departments. How do you focus on when and what you need to focus the education on? And I want to say thank you very much. I'll entertain any questions at this point.
Any questions out there in TV land?
Well, if you click, it will be available on the PowerPoint for CEs, but I've also thrown in some potential quality improvement components. And so in 4 weeks, you can look at these, but I didn't want to necessarily bore everybody, but regular protocol review was one, formal field evaluation of EMS providers, what is your continuing ed? Do you have a formal periodic skill review process in your department? For your transport agencies, a Code 2 response that results in a Code 3 transport. I think everybody needs to look at patient complaints, cardiac arrests, patient refusals and releases at scene, and AED usage. Those are some of the higher risk ones. Some of the other potential ones are King Airway, items on the skills and medication use, delays at scene, etc. Was the splint properly applied, as we talked about earlier? And I think we'll take a short 5-minute break before we continue on with Ms. Kara Davis.
Hello, and thank you for Dr. Rudnick for the informative presentation on the background of CQI. Now we're going to talk about how we put all of this wonderful information into practice. Let's talk about a few forms that we have here. So CQI, where the rubber meets the road. Let's review some of the purposes of CQI to validate practice, to identify educational needs and deficiencies, to recognize best practice, to recognize excellence in patient care, and our goal is ultimately to give the best patient care that we can. CQI is not meant to be punitive, it's confidential. We don't share your information or your reports. We will at some point collaborate the data and put it all together so that we can give you some meaningful information from the data that you're sending in to us. In gathering data in the future, we hope for it to be electronic. Right now, it's mostly paper and pencil. The forms are available on our website. So this is the quarterly overview report form that we initiated recently, and we're going to go through this process step by step. The components of the report form include basic numbers of calls and transports, any personnel issues, problems with equipments and supplies, documentation, education, skills and competencies, transportation and facilities, public education and prevention, risk management, and focused review. When you're looking at the PCRs, it's a minimum of 30 PCRs or 30 runs to review. If you have less than 30, then it's all those runs. If it's more than 30, then all you need to do is review 30. And that's only one run a day to review. Okay, 101C, Quarterly Overview Report Form. The first part is provider agency and year. The year is divided into 4 quarters. The first 2 lines are for first responders. These are medical and trauma responses only. These are not fire related. And most of your runs are going to be called out code 3 emergency. Occasionally you might get called out for a non-emergency response, but mostly your responses are going to be 911 responses. The next 2 lines are for ambulance providers only, ambulance responses, emergencies or non-emergencies, and then number of ambulance transports, because you get called out sometimes and then there's no patient or the patient doesn't need you. So number of ambulance transports from those ambulance responses. And then anytime that you've transferred patient care over to an air medical provider, we'd like to capture that data. How many patients are we having air ambulance come into our region to pick up patients? And any other transfers to other ground providers, and number of interfacility transfers that you did in that month of the quarter. And the first component here is personnel. So does your department have any current personnel issues? Did you have any new hires? Did you have somebody retire? Anybody on a performance improvement plan or orientation? Any other staff transitions? We'd like to know that information. You guys are amazing out there. Equipment and supplies. You have any problems with any of your equipment? And maybe it's a manufacturing problem and it's something that should be shared with the region. Again, it would be shared confidentially. Any problems with any missing items or shortages? Currently, we're having a lot of problems with drug shortages, and we are tracking that in our region per provider. The documentation. This is the peer review audit form 101B in the CQI module. Let's look at this and break it down into some components here for you. The first part is just demographic data, date of contact, date of review, type of call, basic information, history and physical, and you're looking at the documentation. Was this information documented? Treatment and procedures. Was the treatment appropriate? Response to treatment. If pain medication was administered, was the response to the pain medication documented? Again, we're using the number scale to evaluate pain. So if you've given the patient morphine and the pain was a 10 out of 10, after you gave the morphine, did the patient feel better? Is the audit form, is the run review that you're looking for, is it legible? Terminology and spelling and grammar appropriate? Overall evaluation of the patient care report, and any problems with ongoing monitoring, if there's anything that needs to be updated or any education review needs to happen. Education, skills, review, and competency. Did you have any educational events this past month or quarter? Any specific skills reviewed? And did you have any skills, lab skills days where you've checked off competencies? This is what we'd like to get. We'd like to know things that are happening out there. Transportation, vehicles all properly maintained and working when you want them. That's important. You got to get out to get to the call and get the patient back to where you need to go. We want to make sure that everything's being taken care of. Public education and prevention. Are you doing any CPR classes and offering first aid classes to the community, participating in health fairs? Take credit for all the good public education and prevention that you're doing. Risk management. This includes keeping employees healthy and safe. And we would like to see what ideas that you have so that we can share them with other people confidentially. Any focused reviews? Here's some examples of the things you can look at. Number of intratracheal intubations and how that intratracheal intubation confirmation was documented. Vital signs on arrival on scene to patient contact. When you touch the patient, how long did it take you to get your first vital sign? We'd like to see those first vital signs documented within the first 5 minutes of patient contact. Scene times for trauma patients. As you know, blunt trauma, we like to see them loaded up and going in 20 minutes. Of course, if there's a delay for extrication, for penetrating trauma, we'd like that to be about 10 minutes. Blood glucose is blood glucose being determined on all patients with an altered level of consciousness. These are simple things that we don't want to miss in the field. Now we're going to look at another form, Form 303B. It's our AED cardiac arrest form. This helps us to capture the data of our field saves, focuses on each individual event. There's been some current changes to the American heart and the way we do CPR. So is that making a difference to our field saves? This is an overview of the form. Let's break it down into a few parts here. Again, the top part is basic demographic data of the patient, data of the incident, patient's age. And then again, who started CPR? Was it started prior to your arrival, or was it started when you got there? Was the shock initiated, shock advised? And did the patient regain pulses? Was the patient pronounced, transported to the hospital, or pronounced in the emergency department? And then what we finally would like is the patient was discharged from the hospital. Any known complaints of prior to the cardiac arrest, this would be important information that we'd like to gather. A lot of times it's not known, or family members are distraught and not able to give much information. This is for our review. And 303C, AED Statistics Report. This is a form that can be submitted annually. This is an annual report of the synopsis of 303B and gives an overview of the entire year. And there's a snapshot of that one as well. Any questions? Thank you very much.
We're going to talk about the skills and medication usage form. This is, much of it is ALS-centric, and that's why I want to do a BLS-centric one, because we as an agency want to be able to report to the public how well the care that's delivered in the North State really is. And I interact with a lot of people statewide, and if anybody's from Southern California, I'll apologize ahead of time, but it's too centric to Southern California, and we need to make our presence known. So, pretty self-explanatory. Intubation, the basic demographics, chief complaint, PCR. There is something for the King Airway here. The size King Airway, number of attempts. Was there a 12-lead EKG done? Transcutaneous pacing, intraosseous use, CPAP, initial oximetry, post-treatment oximetry. Did the patient improve or not? One of the things that one of my long-term goals, and it actually is allowed in statute, is just a matter of trying to get it out, is some agencies are toying with the idea of making CPAP even a BLS skill. That's being worked out at the state level. One of the reasons why I wanted to develop a ALS as well as a BLS skills and medication usage form, and why we need the information, is to defend our practice. I have people still using verapamil, for example, and I was on a state conference call, and they want to eliminate that from the scope because there are only a handful of counties in the state that still use verapamil, but it's still a good drug. Now, that said, they're thinking of changing it and adding diltiazem instead of verapamil. I don't want to be caught without having a medication, whether it's verapamil or diltiazem, because these regulation changes take time. An example here is Pitocin. This is an outdated medication. I could find no examples of it even being used. So we really need to know whether these medications are being used and how they work in the field. And recently we took Zofran off of the form because it was a new medication. We needed to see how it was being used. We saw it was being used appropriately. So this is a dynamic form that will continue to change. So keep looking for updates, and we send out updates. And if you're able to do, was the patient admitted, AMA discharged, what happened to the patient, so we can start connecting the dots and how these people fared. Because one of the long-term goals that I would love is to be able to give the first responders, the volunteer fire departments feedback on how they're really doing, how they're actually making a difference in patient care. So my hat goes off to Kara, my chapeau. This is some of our data from 2001 adult endotracheal results. 2011, sorry. 2001, I wasn't here. So oral intubation successful rates, first attempt, second attempt, third attempt. The total nasotracheal intubation, there's another movement afoot to remove nasotracheal intubation from the scope at a state level, not just necessarily a Nor-Cal level, and that would be out of my hands. So unless when you perform these interventions, I get the data to defend our policies and how we function here in the North State. If you're in LA and you can take a stone and throw it and hit a hospital from the middle of an intersection on all four corners, then you've got a 5 to 10 minute response time is a long time. We have some providers who the ambulance may not get to the patient for half an hour. And after they initially see and evaluate the patient, it may be another half an hour, 45 minutes to get back. So I need to know what's going on. That's why we're reinvigorating our look at quality improvement in data. Here is an example of some of our pediatric endotracheal use and combi tube use.
Last year's data.
This is last year's data. So Kara put together this nice pie chart, oral intubation successful. Of the ones that we got, we had an 81% first pass success rate, which is actually higher than the national standard. National standard ranges anywhere between 52% to about 80%. Second pass is 14, third pass is 5. One of the things that I'm planning to do, for those of you who don't know, I'm also down in Santa Clara County, and we're looking to do a trial study on a video laryngoscope, which is only $1,000 compared to the $10,000 glide scope. So we could potentially even improve it further. Just food for thought. Just as another way of looking at it versus first, second, and third attempt. But we had 81% successful intubation rates. So looking at CPAP, improved, not improved, total, King airway. I find it hard to believe, guys, that we only use CPAP 5 times. And I also find it hard to believe that we only use the King airway 12 times. Please, I'm down on my hands and knees saying, send me your data. And I want to look at the BLS and ALS data too, the BLS data also, and that's why I'm going to convene the working group, because I want to include everybody. This is how it looks in our usage form, our agency, log number. These for people who are doing 12 lead. So thank you very much. And I'll entertain any questions about CQI, future topics. Just don't ask me for any stock tips because my portfolio is not doing as well as I would like everybody else.
Hi, this is Lilia out at Westside Ambulance.
Hi, Lilia.
Hi, I have a question on the special procedure form. even though we didn't perform any of the skills that are on there, but we did a code 3 transport to the hospital, are we still required to fill out that form and fax the entire PCR to you? Because I know that we've been putting on that form, we read like code 3 transport and circle it, and then we have to fax everything over there.
I like reading those, and I appreciate those.
Okay.
So does that answer it?
Yeah, just double checking.
Okay.
All right, thank you.
You're welcome. Anybody else in viewer land have questions, comments, concerns? Awfully quiet out there. Anybody still awake? I hope.
I have no questions. Sounds good.
Okay.
So Kathy's going to be sending out the evaluation and test.
From Janesville.
Sorry.
I'm sorry, one more time from Janesville.
Yeah. Hi.
Hi.
Hey, on your King Airway form, I noticed there's one slot that the one time that we've had a King Airway used up here in the last probably 6 months that didn't quite fit in any of these. The person actually was probably considered a field safe, but then died in the hospital later. How do you want that classified?
Let's
Patient,
scroll.
it would be patient pronounced in the ER.
Well,
Well, they
with
weren't pronounced in the ER. They were flown off to Reno and pronounced like 12 hours later there.
what I would
Oh.
say is admitted. And if you want to put other, so you can say later on, that would be fine. But initially, that would be an admitted.
Okay. Thanks.
Oh, my pleasure.
And to add on to that, sometimes hospitals, depending on where you go, don't give you that information on if they died later while in ICU or whatnot. Do you just want us to keep it as admitted?
Yes. I mean,
Okay.
for your own edification, you can do that type of follow-up. One of the long-term goals would be, I used to do that when I sign my charts to find out how patients did. Obviously, you're all busy, and if just the patient was admitted, it's fine. That gives us enough data. When years down the road, when we're all electronic and we can integrate the systems, but for now, just admitted is great.
Okay. Thank you.
You're welcome.